Thank you. Perfect. So Laura, thank you so much for the introduction. And I'm so glad to see all the faces here today. Some faces that I do know, some faces that I don't know. So good to see old and new faces. Loretta and I have known each other for a long time because I am a former CIRA postdoc. I was there 2011 to 2014. So it's been a long time. And Loretta's a good friend since we are still thinking of ways of how we can connect and continue to share each other's work. So thank you to Loretta and to the Qualitative group for inviting me again this year and for my entire team. I'm really happy to be here and share with you. I would say the wonderful work that my team has been doing. So today's topic is training the next generation of qualitative researchers, analyzing data from a Photovoice project. I am Tashuna Albritton. I am an associate medical professor at the CUNY School of Medicine in the Department of Community Health and Social Medicine. And a co-presenter with me today is Zaire Bartholomew, who is my research project manager. And so you will hear Zaire for part of the portion of presentation today, as well as the extended team here today. Next slide, please. So the agenda, we'll talk about the outline of the research project, qualitative research methods, training, medical students and qualitative research, the next generation of qualitative researchers, what that looks like, what that means, and we'll open up for discussion questions. Next slide, please. All right. So the learning objectives for today, for you guys who are joining us, number one is participants will be able to, or you all will be able to describe effective strategies for training the next generation of medical students and researchers in qualitative research methods and analysis. And secondly, you all will be able to describe the importance of qualitative research training and medical education and its role in preparing students to understand individual and community experiences, address health disparities, and contribute to meaningful healthcare research. Next slide, please. So here are my team members. Um, the photo voice project that we will be referring to throughout the study is a project actually that was funded through the NIH and actually through Yale Center for Interdisciplinary Research on AIDS. And so I introduced Zaire Bartholomew, who is a MPH graduate from Columbia, 2 years out now, and we have been working together, I think, for 3 years. And so she was um, my research project manager for this photo voice project. Eliza Springer, you will hear from later on today, is a third-year medical student at the CUNY School of Medicine. Jourdain, who is a second-year medical student at the CUNY School of Medicine. Um, and Kayla Hart, who's a first-year medical student also at the CUNY School of Medicine. Eliza is planning to pursue a residency in pediatric medicine. I think Janine's interest is in OBGYN, and so is Kayla, OBGYN. Kayla will actually be doing her MPH at Columbia, probably starting this summer between her first year ending and second year of med school. So I want to give a special shout out to Kayla. Congratulations for her starting her MPH at Columbia very soon. Next slide, please. And I am turning it over to my trusted research project manager, Zaire.
Thank you so much, Dr. Albertson, for that wonderful introduction. And so before we begin the rest of the presentation, I just want to ground us in what does photo voice mean and what does it look like for our participants to engage in photo voice sessions with us. So photo voice is a qualitative, participatory qualitative research method that combines photography and narrative storytelling, which really allows participants to talk, to share and document their lived experiences. And so by doing so, we're able to share our knowledge and to help improve services, programs, and policies. And so on the right-hand side, I'm looking at my monitor as well, but on the right-hand side to see the slides, you see a photo voice map or a photo voice path. And this is specifically the route that our participants went through when they were with us in the photo voice sessions. So we taught them about photo voice, they went and took their photographs, they discussed the photographs and had a reflection session as well. And so we'll get a little bit more into that as we go throughout the presentation as well. Okay, next slide. So qualitative data analysis. So the majority of the presentation today, I'll be speaking directly towards qualitative data analysis because that is what I had the honor and privilege to teach our medical students about during their qualitative research methods with us during this study. And so a little bit about our project outline. So our specific study aim was to really understand the lived experiences and access to sexual and reproductive health services among rural Black women in Alabama across generations and specifically using Photovoice. And so to start out our research study, we did, myself, Kayla, Janine, and Eliza, we did a 3-day intensive Photovoice training with a company called Photovoice Worldwide, where we were able to really dive in and dissect what Photovoice means, how to use it, when to use it, and when it's beneficial to use it, and what do we want to get out of the sessions with our participants. And so after that 3-day intensive training, we went right into participant recruitment, and we had individuals from different community organizations on the ground in Alabama who helped us recruit participants, for our study. And so before we got into our photo voice sessions with participants, we did what we called mock interviews or mock photo voice sessions with Dr. Albritton, myself, Kayla, Eliza, and Janine, where we took turns in different roles as either a facilitator or participant. So making sure that we understood what our slides said, our scripts, and what we really wanted to get out of our participants when they were with us in those sessions. And so from there, we were able to move into photo voice sessions with participants. And so that looked like 2 sessions, an introductory session where we taught them what photo voice was. We explained to them the ins and out of what the study would look like, what we expected from them, and also gave them their photo voice prompts. So basically homework assignments where they were able to take those from session 1 and use that to develop and document the photos that they would bring back to session 2, where we had a larger discussion and talked about their captions, their photos, what it meant, what it felt like to do this, and how did the experience feel overall. And so after our data collection phase, we went straight into our data analysis training, which was happened in three phases. And I'll talk a bit more about that in the presentation as well. And so from the training phase, we went into data analysis, and that looked like a thematic analysis. So really thinking about what are the themes that are coming from the data that we have. And so, for example, some of the themes that we are seeing now as we're in manuscript writing surround education, cultural attitudes and stigmatization, as well as access to care. And so now Kayla, Janine, Eliza, and myself have the wonderful opportunity to support Dr. Albritton in the manuscript writing, and specifically with the sections of methods and results. And so, like I mentioned before, in our kind of roadmap of what our study outline looked like, we had 3 stages of training. So the first one was a data analysis 101, where I really introduced the process of examining data sets such as interviews, open-ended surveys, observations, and documents to really think about and identify the patterns, themes, and meanings that were coming from the data sets that we have. Then we moved into phase 2, where we talked about analysis software. So again, introducing different qualitative data analysis software that helps to organize, code, analyze, and visualize the data. And so the 3 most common software services that we really use and see in qualitative data analysis surround NVivo, Deduce, and Atlas TI. And so from there, we went into our collaborative process. And it's important to know that each of the stages of training went for a number of weeks, but the majority of the time that we spent in our training and in our data analysis happened in this collaborative process. So we thought about cleaning and organizing our interview transcripts, developing our structured codebook, conducting member checking, and performing that initial thematic analysis to identify those key patterns, themes, and meanings. And so now I'll take you a little bit deeper into what each stage of training looked like. So for data analysis 101, we had 4 key themes that we really dived in to look at with data analysis. So we talked about the 5 approaches to analysis, codebook development, key themes and interpretation, and limitations. And it's important to note that with each theme that you see on the screen, we did go a lot deeper, but for the sake of the presentation today, I'll just highlight what those general themes were. And so for our 5 approaches to analysis, we really tried to understand each approach and identify which one best fits. So thinking about narrative research, case studies, ethnography, phenomenology, and also, why am I blanking on the last one? Grounded theory. Yes, grounded theory is the last one. And so once we were able to do that and figure out which analysis helped or which approach would be best fit for our analysis, we moved into our code book development. And so surrounding that specific question is, how do we make sense of the information we have? So we have all of our photos, we have our captions, we have our interviews and all the data with us, but how do we make sense of what our participants were telling us? And so from there, we were able to go into our key themes and interpretation. And that looked like, now that we know what it's saying, now that we know what the data is telling us, how do we organize in a way that makes sense to us and also to our readers in our future manuscript writing. So after that, we moved into our limitations. So asking ourselves again the question, are there any gaps in our analysis? And if so, what caused them? So kind of thinking back into our data collection, were there any questions we could have asked further? Could we have probed in any places a little bit deeper to get a more robust discussion around some of the things that our participants said and told to us? And so I just want to have a brief slide here of the resources used. So Dr. Albritton graciously gave me a number of resources to help me kind of strengthen and develop the trainings to make sure that they were as robust as possible. So thinking about using different literature sources such as textbooks, articles, videos, and things like that to really round out and hone in on our training for our medical students that are part of our team. So when we think about the data analysis software, so phase 2 of the training, we thought about software selection, walking through of the software, and then also independent practice. And so for software selection, that was, we mainly tried to look at and understand the differences between NVivo, Atlas TI, and Deduce. And we ultimately settled on Deduce as a software of choice, being that their user face is very beginner friendly. It's all web-based so that we didn't have to have specific software downloaded to each computer, especially since we're working with medical students and their schedule varies from time to time. So we felt that Deduce was the best option for us to use in this specific data analysis. And so going towards the walkthrough of the software, we had one session where I trained the students on how to use Deduce. And so during that session, we really practiced familiarizing ourselves with the software, the functions, how do I upload, how do I maneuver and use the coding features within the specific software as Deduce. And then lastly, we went into independent practice. So students on their own were able to upload the files and actively work within Deduce to code and get a feel of what it looks like or what it feels like on their own to do that independent practice as well. So moving on to stage 3 and our longest stage, which we're still in kind of because it's always a collaborative process, but we started off with cleaning and organizing our transcripts. So each member of the team was assigned a number of transcripts to really focus on what we call cleaning. And that technically means just de-identifying those transcripts, so removing any identifiable any identifiable markers from those transcripts to make sure that nothing can tie back to specific participants within the study. We then moved into developing our structured codebook. So students took this initiative to develop the initial themes, and revisions and refinements were made as a group. So on the left side of the screen here, you can see what and I'll use the mouse to kind of point, but you can see what our initial codebook looked like. So making sure that we had those research questions at the top of the page so that we can always circle back and remind ourselves the specific questions and themes that we're looking for as we go throughout the interviews and as we go throughout the photos and their captions. So as you can see, some of our initial codes involved education, stigmatization, general perceptions, experiences, and then some of those subcodes that kind of go or fall under those parent codes. So after developing our structured codebook, we moved into conducting member checking. And this is where bi-weekly meetings were held for all members to kind of come together and discuss any reflections, revisions, or just analysis of the interview transcripts, whether it be about transcripts, about the process in general, but just making sure that we're having that check-in to make sure that we are on the same page when it comes to coding the transcripts, and also just hearing from the other members of our team, what does it feel like to be in the process of data analysis. And then lastly, we moved into our initial thematic analysis. And this is where students again took the initiative to synthesize the overarching themes of the emerging that emerged from the interviews as well. So thinking about how do we take what we found from our code book, from our interview transcripts, as well as our photos and captions, and what are the major themes that are coming about from what we have in front of us. And so one specific piece that I felt was really, really important to incorporate into this training was a reflective journey. And this is where we basically took questions and kind of probes, touch points, pain points, and opportunities from stage 1, 2, and 3 to really take a time to reflect and see how do we feel within this process and what things can we tweak or change to make it a better process overall. And so questions, for example, in stage 1, am I really understanding the difference between qualitative and quantitative data analysis? What skills am I developing through this experience, excuse me, and our pain point question that kind of went through each stage. What challenges or frustrations am I encountering? And so I really want to kind of hone in on these questions that I have here bolded, because these were the 3 questions that we constantly went back to and still go back to today as we're in our manuscript writing phase when it comes to a collaborative process. So am I truly listening to participants' perspectives or interpreting them through my own lens? What assumptions or biases am I bringing into my analysis? And what assumptions do I need to check or challenge? And so these, like I said, these 3 questions were our kind of grounding and guiding principles as we went through our coding, as we went through our thematic analysis, and as we are going through our manuscript writing right now. And so just as an example of what that looks like when it comes to that reflective process, I have here on the screen on the left side, you'll see a photo from a participant in their caption, and then 2 quotes from interview transcripts. And so the photo and the caption under the photo reads, "The sun rises and sets daily. No matter the circumstance, it has a duty to give light and the whole earth. Similar to the Black woman, it reminds me of Maya Angelou's Still I Rise. Despite of the Black woman not having significant protection from HIV, we still rise and find a way to survive." And so what we did in this process was we would have the caption, we would have the photo, and we would ask ourselves, okay, initially, what are we seeing? What are we feeling? Where do we think this fits in within our code book? And so oftentimes it would be aligned with what we all thought. So maybe it's education, maybe it's cultural attitudes or stigmatization, and that'll be fine. But there were some instances where we would all have differing views. Well, I think it's education, or I think it's this, or I think it's that. And during that time, we really took the time to open the discussion and have kind of that level setting and that ground setting, and using those discussion questions, as I mentioned before, to really ask ourselves, are we giving honor and reverence to what the participants is saying? Or are we interjecting our own lived experiences, our own biases, or what we think should be saying, or what we think should be said from this specific either photo caption or interview transcript and quote? And so, for example, we would find ourselves sometimes just reading portions of a transcript quote and saying, oh, I think it's education, or oh, I think it's this, and not really reading the surrounding context behind what the participant is saying. So just showcasing how those reflective questions really allowed us to remove ourselves as much as we could, because we're all human and we do that anyway, but remove ourselves as much as we could so that we can really see what participants are saying to us and through the data. So medical students in qualitative research. So as much as the students were able to learn from me around qualitative data analysis, I learned a lot from them around what type of research they did through their medical school education. And so we came to the conclusion that a lot of medical student research really centers and focuses on clinical studies, which involves patient interactions or patient data analysis. And so on the right-hand side over here, I have some examples of the 4 common types of research that medical students do throughout their education. So thinking about clinical research, case studies, translational research, and basic science and laboratory research. And so I highlighted clinical research and basic science and lab research because out of the 4, those are the 2 top most types of research that medical students encounter and do in their medical education. And so when it comes to introducing qualitative data analysis and qualitative research methods, it's important that we are allowing the students to look for the nuance within different themes and different identities and different data sets that we have. And so being able to have our students look for the subtle distinctions, find details and slight variations. And so having their mindset be able to, having their mindset trained on or focus on looking for those nuances allows them to go past kind of that surface level information and really uncover important details that are not always said in other types of research data. So thinking about quantitative for a specific example. And so some benefits for medical students. So there are a number of benefits that medical students can get when they have qualitative data analysis and qualitative research methods as a skill set for them. But I really wanted to highlight this last bullet point here where it says, build skills that are transferable in other areas of medical and healthcare research. And I think this is one of the most important skills that medical students and also researchers can have as they take part and develop this skill set, is because it's not always about necessarily qualitative versus quantitative clinical research versus laboratory basic sciences, but being able to have a skill set that is amongst all of them and use that to leverage and make other skill sets better. So if it's the case that I now know that I can look for these nuances within my quantitative skill set, how can I really identify what the statistics are telling me? And so thinking about how this connects the dots. So like I just mentioned briefly before, statistics, lived experiences, deeper understanding, and advocacy. When we think about statistics, qualitative research is able to add that specific context, that nuance, and that why behind the numbers that we see in those statistics. And then thinking about our lived experiences, qualitative methods amplify individual and community voices by capturing personal stories and perspectives, and specifically in our case, using Photovoice. So being able to allow those participants to really capture and share their lived experiences through photos and captions. And then moving into a deeper understanding. So through the themes and the narratives, qualitative research is able to uncover complex experiences that may not always be reflected in the numerical data alone. And then lastly, so our common goal, which is advocacy. So being able to have those qualitative findings, those themes, those codes, and be able to inform policies and practices that are highlighted in real world challenges, needs, and inequities. And so the next generation of qualitative researchers. So now I'm going to pass it over to the other half of our research team, and we're going to hear from them a little bit about their reflections, their experiences, and what qualitative data analysis and qualitative research in general means to them.
So I'm going to begin by talking about this first bullet point that says why qualitative research and data analysis is important for medical students. In medical school, we spend a lot of time learning how to interpret numbers, whether it be lab values, imaging, how to calculate relative risk versus odds ratio. We even have a course in our school that's surrounding quantitative research using data sets like NHANES and SPARCAs. Those things are obviously very important, but this project reminded me that not everything meaningful in medicine can be captured in numbers alone. A patient's lived experience, the way they describe their barriers to care, their reasons for mistrust or their fears or even their hopes often gives us more context than numbers do by themselves. For example, quantitative data may show Black women have lower rates of preventative care access, but qualitative data explains why. It tells us what barriers exist, how patients feel, what experiences shape those outcomes, and what interventions the patients actually want. Qualitative research explains the why behind the health disparities we're learning about in school. Overall, I think that this type of research and having exposure to it as a medical student is invaluable because medicine is ultimately centered around people, not just diagnoses and outcomes. As future physicians, we're going to be interviewing and caring for patients from many different backgrounds, and being able to listen carefully, recognize patterns in patient narratives, and understand the social context behind the health outcomes is just as important in making us better physicians.
So now I'll talk about reflections on learning and applying qualitative research methods. So this training introduced me to qualitative data analysis in a much deeper and more meaningful way, specifically within the context of Photovoice methodology. We learned how to recognize patterns in stories and how to approach participants' experiences with empathy and intentionality. It reinforced the importance of community voices and how research can be used not only to collect information, but also to empower demographics that have been overlooked. Additionally, as medical students, we are often only exposed to the experiences of those similar to us. Engaging in this process was instrumental in exposing us to the lived experiences of others. In this process, we were forced to remove ourselves fully and honor the voices of our participants, expanding our worldview in the process.
Now I'm going to talk about our future plans on using qualitative research methods. Like Dr. Albritton mentioned, I'm starting my MPH program at the Columbia School of Public Health, and I'm hoping to use my qualitative research skills while in the MPH program. I'm also helping Dr. Albritton and our peers to write for publication manuscripts Furthermore, we have developed and presented this research through a poster at our school's Student Research Day last year. I plan to also use this qualitative skill set that I have to write and publish with other scholars who are also interested in doing qualitative research, especially in the areas of maternal and infant health, which I am also very much interested in.
Thank you so much, Kayla, Eliza, and Janine, for your reflections and your takeaways, as well as, being a part of the qualitative data analysis training and just being a part of the team in general. All right. So our next slide, we have a few discussion questions that we wanted to pose to the audience to just kind of get us into a larger discussion around qualitative data analysis or just qualitative research in general. And so our first question reads, how can qualitative perspectives improve our understanding of health inequities across diverse populations? Our second question, what perspectives do individuals and communities bring that may be overlooked when healthcare disparities are examined through quantitative data alone? And our last question, what qualitative or mixed method approaches have you used in community engaged research? And we can also put these questions in the chat so that we can remember them as well. And then our last slide is just thank you to everyone that allowed us to present today, our funding, CIRA, as well as the Qualitative Research Discussion Group. And we thank you all for giving us the time to talk about our experience using Photovoice, as well as our data analysis training.
Well, I thank you all for a fascinating and thought-provoking and very efficient presentation. I'm going to just start off. Are you going to put the questions in? Yes. Okay.
Or you can just go back to that slide and just leave it up.
Oh, yeah, okay. That would be fine too. But give them to give the people a little bit of time. First of all, I wanted to comment. It really was wonderful. I was so terribly impressed. This is where you really hit deeply for me, is the training did things that I feel are often lacking in medical school education. I kind of hesitate because I think it is dealt with to a certain degree much more in psychology or in social work. So there's other places, clinical settings where you might get more exposure. But the whole thing of how to communicate and how to listen, I think is one of the most wonderful things. I know it's not the one that you highlighted, but it's the one that spoke to me the deepest, in that it's a skill that will transcend any qualitative research that you will do to your clinical practice. If and when you decide to go into clinical practice, you have a much better understanding of what it is to communicate and also how to keep yourself in the conversation, but out of the conversation. In other words, what is your own stuff and how is that affecting how you're hearing things versus what is the person really trying to tell you. So wonderful, wonderful job. And if there is anybody who has, wants to respond, I'm just kind of going on a little bit here, but just unmute yourself. There we go. Aranima.
Hi everyone. First of all, great presentation. It was so nice to see how to use qualitative data and how to go through the coding process and the future takeaways. But I understand through this presentation, you discussed about having frequent meetings to come together to set up a singular code book when working with multiple coders. But when I was working in my team and I was also working on coding these transcripts, I have noticed that individual coders can have biases when it comes to picking up on the different nuances that our participants are talking about. So one of the examples that I faced was that in my participant pool, they talked about lack of family support, or they were sarcastic in some forms, and some coders kind of coded that as a resignation, like the tone as something that was sarcastic or resignation, while someone else kind of misunderstood the tone and coded it as something else. And we too had frequent meetings to set up um, the interreliability of these coding frameworks. But I was wondering, would you suggest any other strategies that we might come up with that beyond the frequent meetings that we currently do to address these variability and the potential biases? And thank you again. It was a great presentation.
Zaire, I think we both can maybe answer this question. So
Okay.
first of all, that was a great question. I love that question. Um, I think that when you are doing qualitative research, that there's a level of conditioning that one has to do within oneself um, to really think about some of those steps that Zaire took our team through. Um, what am I looking at? What am I understanding? What am I feeling when I'm actually reading this text? Why am I feeling this way? I think that, but I would say it's easy for me because I am trained in the discipline of social work. Like I have a master's in social work, I have a PhD in social work. I used to be a clinical um, social worker, but now I only do research. So, I'm privileged in the sense that I've had that type of professional and formal training, right? But I do think that there is um, a space that teams need to carve out to kind of do some of that work, to revisit really what it means, what qualitative data really means, what do the voices of communities or patients really mean to them. What are they actually looking for? What is the goal of their project? Is the goal to really, is it to push an academic agenda because we have to publish, we have to do research, right, as academics? Or is it really to kind of elevate the voices of the individuals who participated? Is it really to bring attention to a topic that could influence advocacy structures as well as policy? I think that a team is really important for teams to spend that time to do the work, and it's hard and it's uncomfortable, and a lot of people don't want to make space for it. Or sometimes it depends on the funder, like you might not have time, right? Everybody's on a timeline, but I think you can write that in into grants as part of a process. You can bring someone in who may, professionally do work around health equity, community engagement to talk to the teams. And I've actually, as a PhD student many, many, many years ago, we actually had a consultant on our team who did just that. And she challenged our beliefs, our lens, our biases, right? So that when we actually began the work, like we were conditioned, deconditioned, reconditioned over and over again until like we were really primed to do this work with communities and to actually work with this data. And so but again, that takes time, and the PIs of the study have to be willing to do that and recognize the importance of that. Because what your team was doing was correct. I mean, that's exactly what Zaire just described to you that our team did. Um, but I would say we work within a culture, a context, even within our med school, that, population health and social determinants of health is threaded through the entire program from beginning to end. So from the conditioning standpoint, like our students are conditioned to hear about what we would consider vulnerable populations and the disenfranchised, sorry, I can't read.
Emphasize.
Thank you. Thank you. Oh God, I'm sorry, right? Why I can't pronounce this word, but um, what they experience, right? So there is some conditioning that's been going on throughout the program. And so when students work with me, I mean, this is the kind of work that I do. I do community engaged work. And so, I kind of re-emphasize kind of what they've been learning in coursework in the program. And so Zaire, just turn it over to you.
Yes, and just one quick thing. I would also say that it happens more often than we think when we're coding and we're like, well, I got this, well, I think this. And so one of the smallest things that we were able to do to kind of again refocus ourselves, in addition to the reflective journey, was really to go back to the definition of the code. Because sometimes we would just you read the transcript and we say, oh, that's education. And then we'd be like, but wait, what does education in this context specifically mean? And then that clears up so many things, right? Because we forget that there's a definition that we wrote down because we have this, conditioned definition of what cultural attitudes or stigmatization may mean. But then when we're like, oh, it happens so many times, we would come together and be like, well, let's go back to what the definition means. And when we did that, we're like, okay, it cannot be this. And we would move on, right? So making sure those small, small things that you integrate back into that reflective process can help tremendously. But it happens. I think sometimes I like it when it happens because it challenges us to be like, are we thinking about this right? And so, yeah, love and hate relationship, but definitely using that definition of the code to kind of help you reground and recenter.
Karen, I see your hand is up, but I want to add something to Tashana and Zaire because yes, I agree with both of what you, but I would add on, I love having the code and the definition in front of us at all times. But what I also have that I add in as we progress with our discussion of codes and transcripts is in a different font or bolded examples or rules about how to apply. So in my definition block, cell in for a given code in my Excel spreadsheet, because that's where I keep my code book, I will also have not only the definition, which will help you when it comes to writing your manuscript, I will also have whatever we have decided as a group as a rule or as a good example. So that's just the other thing that I would add on top of what you both said and are spot on with at least
Yeah,
one way.
because the one thing that I found really helpful was I had memos and I talked about how we should all keep memos of the entire process
Yeah,
just so we could talk about what we are thinking while
yeah.
we coded that and just have that discussion of does that make sense? And if it does, then let's change it. So I was wondering, thank you so much. This really
Yeah, thank
helps.
you. Thank you. Great question. Your
Yes.
memos are excellent.
Yes. Keep a log.
I think Karen was going to go next.
So as a medical anthropologist, it's so exciting to see this discussion happening in a medical space, because, it's so important and it really does make a substantive difference. And just in terms of the qualitative or mixed method approaches that I use in community engaged research, one of my favorite things, and it is labor intensive and it's tricky, but it's participant observation. Because what we do, what we say we do, and what we think we should do are very different things. And when dealing with populations that are often silenced, and sort of impacted by hegemonic influences, you really get to see that when you're doing the participant observation, because you can see those power dynamics, you can pick up on that sarcasm, you can sort of get that depth of knowledge that is very difficult. And even within medicine, like semantic inoperability, like when people are, doing pull down menus and stuff like that, like you can watch how they look and interact with clients and how they interact with systems. And so much of that richness in medicine tends to get lost because it is a field of workarounds. And so I must say, like, just that is the richness that qualitative experiences really does give you. And it's so exciting to see this work and the outputs you're getting from it. So.
Thank you, Karen. Karen, can I ask, like, what setting do you actually do your participant or a patient observation?
So I'm a little bit of an odd fish. So I was integrated into a healthcare team. So I was actually lucky enough to be able to observe clinician encounters. So I worked with populations with MCIs and dementias. So when I was embedded in the care team, it was a little bit easier to sort of do that work. now, as someone who's employed outside of healthcare and having to come in as a researcher, it tends to be more like waiting rooms, public spaces, social spaces. So I don't get that same level of intimacy, but because you have to build that trust with the clinicians, and it does impact that dynamic.
Yeah.
But even just seeing, like, even if you just sit in a clinic and you get to sort of see the hallway conversations that happen, even though I don't pay attention to the detail of what those are, or seeing the flow of the clinic, like just being able to pick up on those, even seeing people's body language in waiting rooms, how much they advocate, how long they're willing to sit before they come forward and sort of advocate for themselves. Like
Yeah.
seeing all those dynamics, the sort of unspoken
Hmm.
context allows for so much richness where you really do see where populations are more overtly and internally reacting to their environments.
That's
Yeah, waiting
wonderful.
rooms are amazing. If you can just spend time in waiting rooms, it's so incredible.
Actually,
People watching.
you're touching on something that is also an issue, a great comment for me is when you're studying stigma. So I basically look at stigma as being anticipated, internalized, or actual.
Mhm.
And when you're talking to the person who is telling you about a stigmatizing experience, I always have this hiccup in my thoughts of, are we really talking about an actual stigmatizing event? Because we don't have that third person who's sitting to the side and can kind of observe and be that triangulation, if you will, process of, was this actual stigmatizing, or was this perhaps more the anticipatory kind of stigma? And it's the power of having that other person to observe, that trained person to observe, that I think is often missing, and that we just have to deal with in some way if we're not so fortunate to have people like you, Karen, to do that work.
Thank you.
Are
We're
there
happy.
other questions? Yeah.
We're happy to entertain any questions related to the project, to the presentation you just saw, or kind of to the larger Photovoice project. If you have questions, happy to
I
answer.
was wondering, one thing was about, did you or do you intend to do, I don't have a sense of the volume of transcripts that you've got, of data, because it's data of transcripts and photos. Are you doing anything in terms of calculating? Do you intend to calculate intercoder agreement, or I know other people will sometimes use, is it the kappa? I do not use the kappa, but are you planning to do something to that effect?
Yeah, I think when Zaire and the students first um, kind of did their practice coding, I think that that's when they did the kind of the inter-rater reliability, because we wanted to kind of see the level of agreement and across coding before they finished coding the transcripts in totality.
Uh, and the other question would be, did all of the students uh, code every one of the transcripts, or was there a certain point when you reached adequate intercoder agreement, did you divide and conquer so that you did? So in that case, do you intend to bring them back? Because they're not, oftentimes you have drift. You have drift even of yourself if you don't have the definitions in front of you. And even with the definitions in front of you, over time you will drift in your coding. But it's kind of multiplied if you've got several different coders for a given project, to drift over time, and the intercoder agreement might go, decline to the point where it's not good. So an interim where you all come together and independently code the same transcript midway through coding, something like that.
I mean, Zaire can speak to this, but I don't think that, I mean, we didn't have a lot of transcripts. I think we're working with like 11 transcripts maybe.
11.
So it wasn't not a huge number. Um,
Yeah, no, that's
yeah. And so Zaire, I don't know if you have anything you want to add to that.
And I was just going to say, we did have 11 transcripts. And so we did this. So the second part of your explanation. So when we got to maybe 3 or 4 transcripts that we did together, then we realized, okay, now we can independently go on. Because, and also what was beneficial was that Kayla, Eliza, and me, we were all kind of together on those Photovoice sessions. So when we were reading the transcripts, we remembered like, oh yes, I remember this participant. I remember this conversation. So it was kind of like a third, fourth pass at everything because we were actually the facilitators in those sessions. So it was double-edged sword because you're like, okay, well, I remember this, or I, engage or put that on it. But because we did have that limited number, so 11 transcripts, it wasn't, a robust number where we had to kind of keep going back and forth and, oh, did I, mistake here, or am I, in the same kind of coding pattern as my team members?
excellent point that, volume of data certainly can describe, define the decisions that you make along the way. Thanks, Zaire.
Did anybody make, because I've looked at Photovoice and it's so interesting to me. Did any participants like share their ideas or feelings about the data collection strategy? Like, did anyone talk to you about Photovoice?
Yes. So session 1 was introduction. Session 2 was when we came back and had the discussion. And we also offered a third session where you could come back and share more of your experiences. But we found that in session 2, that happened as well. So as they were talking about their photos and their captions, they really, at the end, we left space for them to kind of talk about the overall experience. And a lot of the participants was like, this was a really, really cool and incredible experience because I never thought that you could say so much with a photo. Like we all know a photo is worth 1,000 words or 1,000,000 words, whatever the quote is. But it was really, it really came to life with each participant. And so it was really, really cool to see, like we would see the photo first. So just a little bit of background on how we would set up the session. We would have the participant just show the photo and we would all just look at the photo. And so at the end of maybe like a minute or two, then they would put the caption. And so to read the caption, be like, I would have never guessed, or I would have never thought that this was where you were going with it. So we all had that kind of like, ooh, ah moment. So in those sections, participants really explained to us how much they enjoyed that kind of photo taking and then adding the caption to that as well.
One memory I have when Tashuna and I were in training on Photovoice was one of her photos where nobody in the room had any idea.
Oh my God.
Tashuna.
I remember photos. I don't remember which photo you're talking about.
Oh, no, later on. I was going to say also to Eliza's comments, one of the things that I think that I really picked up in what you said, and valuing the experience of getting good training on qualitative methods is, I think we're all kind of in the same opinion that it's probably communication skills, qualitative research is not terribly stressed even today, even though it's been around for a good long while now in medical school training. So, but the fact of the matter is there is more and more and more qualitative research that's being published, mixed methods research that's being published. And if you don't understand, then you're in a one down position, or if you think you understand, but you really don't understand what the qual portion is about, and you just keep your quant hat on while you're looking at qual results, then you're really not getting it. So I think that, Eliza, you were speaking to the value of this in your future, not only as a clinician, but also as a researcher or as a clinician looking at research. I think that's wonderful.
But I think that, Loretta, to your point about kind of maybe how people are viewing kind of text data, qualitative data in general, its importance is that, when you're teaching students to really understand systems, particularly how you want your students to really be able to identify health inequities or health disparities, um, that you never know what space you're going to find yourself in.
Yeah.
And to be able to kind of talk about or present data, or even have, participants who are willing to show up in these district community health meetings or at your state senate. You can have the numbers in front of you, but it is the voice and experience of the people that also adds to the shift in the room. And so you can't underestimate what people, and I say this in air quotes, is what they consider soft data. There's nothing soft about people's lived experiences, particularly if they're unjust and unfair.
Mhm.
So, as an educator, I'm not just a researcher, I'm an educator. So if I'm teaching or, working with students who are working on my projects, I'm always challenging them to kind of think about how are you going to use this to advocate for those who can't advocate for themselves? How are you going to use this data to come against the system that's going to tell you how to practice medicine, that determines how you get paid? So, and how much time you can spend with patients. So, um, I think this is my opinion. I think programs kind of do injustice if they don't equally value quantitative and qualitative work and what that means in settings, particularly around healthcare. Um, so anyway, that's just my 2 cents.
No,
But I
and I
wanted to,
agree. I agree with you totally. I would say from my own experience, I'm self-disclosing to you all, but I had a pediatrician when my kids were young. This one pediatrician, even though they are all under the gun, that they've got 15 or 20 minutes tops with each one of their, well baby checkups, she was able to make that 15 minutes really productive, that she was able to hear in a certain way and she was able to communicate in a certain way that I always felt, and I was already a clinical psychologist at the time, and I was thinking this woman really gets it.
Mhm.
About it's not about I need more time, it's how to best use and how to be trained to best use that time to understand from the perspective of the community or of the person what is going on. And that goes back to what I was saying about communication skills.
Mhm.
Uh, yeah, I mean and I think we're dancing around the maypole of, empathy. I mean, I think empathy to a certain degree, either you are empathic or you're not. But then again, I think everybody, like some people are better at communicating, just innately. But everybody can be taught to
Yeah, I
be
agree.
sensitive, to understand what's going on in themselves and how to communicate effectively and listen effectively to the other person. There is a skill that can be trained, I firmly believe.
Oh yeah, absolutely. I completely agree with you, Lorena. Completely.
Well, we're almost at the top of the hour. I thank you for a wonderful discussion, and I wish all of you the very best in your endeavors as you progress through med school and into research and all that wonderful stuff that lies ahead for all of you. Thank you so much,
Thank you.
and have a wonderful weekend.
Thank
Thank
you so
you.
much, Loretta. Take care.
Take care. Bye bye.